Welcome to our session today. It's titled Integrated Artificial Tear Formulations and Neuromodulation in the Management of Ocular Surface Disease. I'm Ian Pitha. I'm a glaucoma physician and I'm Associate Director of the Alan Crandall Center for Glaucoma Innovation at the University of Utah. Presenting with me today is Dr. Stephen Flugfelder, who's professor in James Margaret Elkins Chair of Ophthalmology at Baylor College of Medicine. Today, the presentation's been supported by Alcon Vision with an unrestricted educational grant. These are some accreditation statements. For certificates, please remember to complete your evaluation by 6 months from now, which will be December 9th in 2026, in order to receive credit. We have a disclosure of unlabeled use and a disclaimer that you can read. And planner and speaker disclosure policy as well. These are my and Dr. Flugfelder's financial disclosures. And let's get on to the learning objectives of today. So the learning objectives of today are to integrate the evidence-based information on the pathophysiology, risk factors, and evaluation of ocular surface disease, and to implement data on artificial tear formulations and neuromodulation in the management of ocular surface disease as well. Here's the agenda. I'll be presenting first, and over 30 minutes, I'd like to present an overview of the pathophysiology, evaluation, and artificial tear formulations for ocular surface disease. Dr. Flugfelder will be presenting second. He'll be discussing data on neuromodulation and managing ocular surface disease. That'll be followed by a panel discussion and questions as well. All right, so to move on to my presentation, I'd like to start with a clinical vignette. So here we have a 68-year-old woman who presents with fluctuating vision, burning and worsening symptoms late in the day. Examination of her demonstrates lid margin telangiectasia, thickened meibum, reduced gland expressibility, rapid tear breakup time, and did something called meibography showing gland dropout. The Schirmer test is normal in this patient. So which of the following is most likely the primary mechanism driving her ocular surface disease? Aqueous tear deficiency, goblet cell dysfunction, meibomian gland dysfunction, neurosensory dysregulation, or lacrimal gland insufficiency. And we'll come back to this question, I think, at the end of my presentation. But now I'd like to move on to an overview of pathophysiology, evaluation, and artificial tear formulations for ocular surface disease. So these are the objectives of today's discussion. First, we're going to define ocular surface disease and discuss why it should be viewed as a family of disorders rather than a single disease entity. Second, we'll review tear film anatomy and physiology. I know that sounds really basic, but understanding normal tear film function is essential for what we want to understand today. Third, we'll review the major mechanisms that drive ocular surface disease. Fourth, we'll discuss practical approaches to evaluation. And finally, we'll spend a pretty substantial amount of time discussing artificial tear formulations. This is often an area where patients have the most questions. They walk into a pharmacy and are confronted with dozens of products that all claim they're going to really effectively treat their dry eye disease. So what is ocular surface disease? And I have an umbrella here because it's really an umbrella term. Most patients use the term dry eye. Some clinicians use that term interchangeably. However, ocular surface disease is actually much broader than dry eye alone. The current definition describes dry eye disease as a multifactorial disease or umbrella disease of the ocular surface, and it's characterized by a loss of tear film homeostasis. Historically, dry eye was often thought of as a problem of inadequate tear production. The assumption was simple. Symptoms occur because there aren't enough tears, but that's not really the full story. Many patients with significant symptoms have normal tear production. Others may actually demonstrate excessive tearing because of reflex tearing that's being stimulated by surface irritation. Other patients have inflammatory disease, some have neurosensory dysfunction. We're going to touch on all of those today. But the thing that unites all of these syndromes is a disruption of tear film homeostasis. So one of the greatest challenges in ocular surface disease is the impact. It's frequently underestimated. So unlike glaucoma, patients don't go blind. Unlike retinal disease, they don't lose their central vision. Unlike cataracts, they don't develop an obvious opacity. Yet the burden can be pretty enormous. Patients frequently describe fluctuating vision that interferes with reading. They report difficulty working on computers. They struggle with prolonged concentration. Driving at night becomes difficult. And you can often ask the patient the simple question, what activity bothers you the most because of your eyes? And the answer is really remarkably consistent among our patients. Reading, computer work, driving, watching TV, contact lens wear, anything that really demands a lot of patient attention. Um, What's particularly interesting is that this vision itself often becomes part of the symptom complex. Patients may not describe blur in the traditional sense. Instead, they describe vision that is unstable. But the quality of life impact for moderate to severe dry eye has been compared to, it's fairly substantial. It's been compared to other chronic systemic diseases, such as moderate angina, where so limitation of ordinary activity like going upstairs or dialysis-related symptom burden. There are a number of non-ophthalmic risk factors for ocular surface disease. Demographic features certainly play a role, as with every disease. The older you get, the more common it is. Ocular surface disease is a little more common in women than men, and especially in postmenopausal women. And, there's also the thought that people can have a genetic disposition towards developing ocular surface disease. Environmental factors are increasingly important in modern society. Think about how many hours the average patient spends looking at screens every day. When we focus on digital devices, blinking frequency decreases dramatically, incomplete blinking becomes more common, tears evaporation occurs, and dry eye becomes more of an issue. Um, In many ways, modern lifestyle are almost perfectly designed to promote ocular surface disease. Environmental conditions also matter, like low humidity. I'm in Utah here, it's very low humidity, and ocular surface disease is very common here. But things like air conditioning, forced air heat, airplane travel, prolonged visual concentration, all of these contribute. Systemic disease is another major category. And finally, medications are often overlooked as a risk factor for developing ocular surface disease, but many of the common medications that people take are associated with the occurrence of ocular surface disease. There are other risk factors that I'm not going to touch on really that much today, but people with sleep disorders, obstructive sleep apnea, or chronic inflammatory diseases can also suffer from OSD. So tears, what's their role? Before we spend time just discussing the actual disease, I think it's important to spend a few minutes talking about normal tears. One of the reasons is that tears actually do a lot in kind of maintenance of the health of our eye. They play a very important role in maintaining optical clarity and lubricating our surface and creating kind of a comfortable environment for us. They also are an important barrier to pathogens. They provide nutrition to support cells on the surface of the eye. Um, they maintain the osmotic balance of the surface of the eye, and they actually play a really important part in wound healing if your eye is ever injured or you ever have a corneal abrasion. So tears are kind of a remarkable thing that are often unappreciated by people who don't obsess with them every day, um, like us ophthalmologists. But historically, we were always taught that there's this classic three-layer model of the tear film. There's an outer lipid layer, Then there's a middle aqueous layer or the wet layer, and then there's an inner mucin layer. And today we recognize that these layers aren't really truly separate structures that are stacked neatly on top of each other. Instead, they function as kind of an integrated continuum. So the lipid layer, which is on top, is produced primarily by a gland called the meibomian glands, which live on the margin of your eyelid. Its primary role is to slow evaporation and stabilize the tear film between blinks. When this layer becomes deficient, evaporation accelerates and dry eye gets worse. The aqueous component originates primarily from the lacrimal glands, the tear glands. It contains water, electrolytes, proteins, some antimicrobial molecules, and growth factors and nutrients. It provides hydration for the eye. It's what we classically think of as the tear gland, right? And then closest to the epithelial surface is the glycolax and mucin-rich interface. It's produced by the goblet cells that live on the conjunctiva. And the mucin layer allows tears to spread efficiently over the eye. But the key concept of this slide is that disruption of any of these components destabilizes the entire system. Meibomian gland dysfunction affects aqueous stability. Goblet cell dysfunction affects the spreadability of tears. And one thing we're going to learn is that inflammation really affects everything with tears. Now begin discussing what actually goes wrong in ocular surface disease. So this slide summarizes some of the major players in dry eye disease. So inflammation is a major player, hyperosmolarity of the tears, meibomian gland dysfunction, goblet cell dysfunction, neurosensory abnormalities, which are really interesting. And importantly, these processes rarely occur in isolation. So once the system loses homeostasis, multiple positive feedback loops can begin to drive disease progression. So let's start with inflammation. It's one of the central drivers of ocular surface disease. In many ways, it serves as a common pathway through which multiple forms of OSD produce tissue damage. When tear film instability develops, epithelial cells experience stress. In response to that stress, they begin releasing inflammatory mediators. These mediators include cytokines, chemokines, and numerous other signaling molecules. And these signals recruit immune cells and amplify this immune inflammatory response. As the inflammatory response progresses, epithelial integrity deteriorates and the function of goblet cells decreases as well. And this is just a cycle that goes on and on. One of the most important concepts for clinicians is that inflammation can persist even after the original trigger has improved. So this helps explain why some patients continue to experience symptoms despite, apparently adequate lubrication in the setting of inflammation. Tear hyperosmolarity. If inflammation is the engine driver of tissue damage, hyperosmolarity is often considered the spark that starts a lot of this fires or that fire. It's one of the most important concepts in modern dry eye pathophysiology. It can occur when water is lost from the tear film faster than it's replaced. As water evaporates, the concentration of solutes increases. That stresses cells, which causes inflammation and causes a cycle of ocular surface disease as well, which includes inflammation, loss of barrier function, and surface damage. And then this affects tear film stability. It's particularly interesting because it occurs in both major forms of dry eye disease, and this is one concept to touch on. It occurs when we have aqueous deficiency disease because there's insufficient tear volume. The lacrimal glands aren't making enough tear. And it also occurs in evaporative disease because tears disappear too quickly and concentrate on the surface of the eye. So they're different pathways, but they have the same endpoint. I'd like to spend a little more time here discussing meibomian gland dysfunction because, in my opinion, and I think in an evidenced opinion, it's probably the most important slide in the entire pathophysiology set. If I had to choose one mechanism that's responsible for many dry eye symptoms seen in routine eye care practice, it would probably be meibomian gland dysfunction. So the meibomian glands are these modified sebaceous glands. They're located within the tarsal plates and release They're lipids along the margin of your eyelid. That lipid layer serves as the protective barrier that slows evaporation and stabilizes tear film between blinks. So when these glands function well, tear evaporation occurs at a relatively controlled rate and people are comfortable. But when they become dysfunctional, everything changes. So the classic model of meibomian gland disease involves duct obstruction of these glands. The gland orifice becomes blocked. The meibum within the gland accumulates within the gland. That leads to inflammation, and the quality of the lipid secretion decreases significantly. It's fundamentally an evaporative disease, so tears are evaporating more rapidly than is ideal. And we'll talk more about gland assessment later in this talk, but that deserves a great amount of emphasis in your examination of people who are complaining of dry eye. Um, People who have very severe meibomian gland deficiency can also have gland dropout and chronic insufficiency of their meibomian glands. And that's one reason why early intervention matters, because if you're having gland dropout, it's a very hard disease to fix. Um, and the next category is goblet cell dysfunction. So we're moving from the surface of the eye of the tear film to the base of it, the mucin component of the tear film. Goblet cells are found on the conjunctiva, white part of the eye, and also in the fornix behind the eyelid. And they're often overlooked in clinical discussion of ocular surface disease, but they're rarely, very important. These are specialized conj cells. They produce mucin that helps maintain the wettability and tear film stability. With adequate mucin production, tears spread properly across the ocular surface. When you're mucin deficient, they do not spread properly and do not adequately hydrate the surface of the eye. The major cause for goblet cell dysfunction is inflammation. That can lead to goblet cell loss, but medication toxicity can also do this, as well as environmental stress. And then the last category I'm going to touch on is a very important one, neurosensory dysregulation. This is one of my favorite slides because it addresses one of the most confusing aspects of ocular surface disease. So we've all been in the room and we've encountered the patient who reports severe burning, pain, light sensitivity, all the symptoms of dry eye. And then you look at their eye and it looks perfect. Staining's minimal. Tear parameters are only mildly abnormal, and the patient's just miserable. And we've also seen the opposite, a patient who has significant disease, severe meibomian gland disease, a lot of staining on the surface of the eye, and they're fine. They might have a little blurry vision, but they're not symptomatic at all. So why does this happen? It likely involves neurosensory dysfunction. Cornea is very densely innervated. These nerves are not simply pain receptors. They maintain the epithelial health. They participate in wound healing. When corneal sensory pathways become dysregulated, symptoms can become disconnected from their structural findings. So patients can develop hypersensitivity or they can develop a reduced sensitivity as well. And this becomes very important in kind of our evaluation of patients. So putting it all together, I really kind of trying to beat this in is that this is not a, dry eye and ocular surface disease is not a linear process. It's more iterative and cyclical with one insult causing kind of this snowball effect to lead to dysfunction of tear film homeostasis and symptoms. So, on initial presentation, I often think it's, the patient tells us what's really bothering them. And they often give you the diagnosis without asking a single question. They have a number of words that they're going to use in describing their dry eye disease or their ocular surface disease. Dryness, burning, foreign body sensation. Some pearls are that it often fluctuates. It's often environmental. And, there can be this dysenergy between visual symptoms and discomfort. Some patients are going to be mainly complaining about discomfort. Others are going to have the visual symptoms, but it's going to be cyclical. It's probably going to be environmental. and it's going to have a few of these key words without you even trying to kind of ask any questions about it. But then I do think some targeted questions can be very helpful in evaluating our patients. What are the predominant symptoms that are bothering you? When does it happen? How often does it happen? And how much of the day are you bothered by it? Are there any environmental cues of when this happens? Is it when you're driving? Is it when you're at home? Is it primarily when you're working that can really give you some hints about how to treat this, but also point you to the diagnosis? It's also important to know how much it's really bothering them. Are they just looking for something to complain about, or is this, one of those dry cases that is really affecting your patient's life? Have they tried any treatments? And then, I think it's always important to look at their medications and their health overall. There are patient-recorded outcome surveys that can be used. I don't really use those in my practice, but the OSDI and DQ5 are two, and they're very well validated. They can offer direct quantification and possible insight into causes, but I don't use any of those in my evaluation of patients. So then we come to the physical exam. And there are a couple things you want to look at. You want to look at the stability of the tear. If you have a slit lamp, you can look at the tear breakup time. Generally, is it greater than 10 seconds or before 10 seconds do you see uh, dark spots appearing? Look at the volume of the tears. You look at the tear film meniscus. You can do something called a Schirmer's test, which actually kind of quantifies the amount of tears that you're forming. And then there's some other tests you can do. You can look at the osmolality of the tear using a point of care tool. But the, essentially, you're looking at the tear volume and its stability. And please remember that tear film deficiency doesn't necessarily mean dry eye. Many symptomatic patients have a really normal tear production when you're looking at that meniscus. Um, I think that this is a very kind of telling picture. This is someone with meibomian gland deficiency. You see those telangiectasia along the eyelids. You see capping of those glands if you really zoomed in it. If you try to express them, if you try to press on the eyelid to express those glands, you're not able to get anything out of it. You're not getting the nice clear mucin or lipid layer out of it. And these are just those beefy red eyelids that are kind of pathognomonic of meibomian gland deficiency. Can be seen in conjunction with rosacea and skin disorders around the face and eyelids as well. There's some tools called meibomography that can actually let you look at the glands within the tarsus. And when you look at those, you'll see shortening. You'll see those glands occasionally drop out as well. Demodex can cause meibomian gland deficiency. There's some medications to treat that. I don't see that often though. You can look at the ocular surface using something like fluorescein to look for staining, which stains uh, epithelium that is no longer there, and kind of gain by the amount of staining you get, you can kind of gauge it or grade it from normal to severe. Lissamine green is another stain we use. It's not fluorescent. It's green and it is a little more sensitive. It stains devitalized or stressed cells. So basically, you're trying to bring everything together, mechanisms, the signs, and the morbidity, and kind of figure out where your patient is on this in order to treat your patient. I want to. I'm a glaucoma specialist. So I want to take 2 minutes just to talk about benzalkonium chloride, or BAK. It's a preservative that's used in a lot of our glaucoma medications, topical medications, and it's actually not a single molecule. It's a whole group of molecules that's bactericidal and fungicidal to a certain extent. It's not 100%. It doesn't protect from contamination, and there have been some bacteria, especially Pseudomonas, that have been found to be resistant to BAK. But the reason I want to talk about this is if you have a glaucoma patient and they're complaining of dry eye, the preservatives within the drops they're taking could be playing a major role. If you look at the ocular surface disease index score of glaucoma patients who are taking drops and the number of glaucoma medications that they're on, certainly the more glaucoma medications you're on, the worse your symptoms get. So if you encounter a patient who's complaining of dry eye disease and they have glaucoma and they have a significant drop burden, that is probably the inciting factor and often won't get better unless you modify that drop burden. So you might want to talk to their glaucoma specialist about doing that. But in terms of therapy of dry eye disease, you want to treat the cause and break the cycle. Give some lifestyle modifications maybe to help them, and otherwise replace tear deficiency or stabilize their tears. And we'll talk a little bit about replacing the tear deficiency or stabilizing their tears because what you're basically using is something called an artificial tear. There's so many kinds of them. If your patient goes to the pharmacy, they're going to see a whole aisle of artificial tears that all claim to be miracle cures for dry eye. Often the patient actually has to figure it out themselves. They pick a drop and they move from drop to drop until they find one that really works for them. But ideally, what we'd like to do is choose our artificial tear formulations based on the underlying cause rather than the preference alone. Um, there are different lubricants that are used. They're all polymers, but they all have different features. And if you go from tier to tier in the pharmacy, they're all going to use different polymer lubricants, and for reasons that are well thought out, but can make this even more confusing. And then often tiers will have other ingredients. They'll have lipids to recreate the lipid layer of your tier. And they can have osmoprotectants like trehalose that protect against that damage from hyperosmolarity. And if you look at a list of artificial tears, which I'll give you in a second, you're going to see that there's different combinations among all those artificial tears. But looking at artificial tears kind of in a general way, think of the mechanism of their disease and what you're trying to fix. Are you trying to fix uh, just replace their aqueous? Do they have meibomian disease and you're trying to replace their lipids? Or do you think that this is an evaporative disease and you're trying to provide some osmotic protection? So you're going to be looking for specific ingredients, ideally. And in artificial tears, thankfully, we're not using BAK. We're using a number of different preservatives, which are much less toxic than BAK. So that tends not to be an issue unless you're using artificial tears more than 4 times a day, in which case I would recommend your patient use preservative-free artificial tears. So here's a list of commonly found artificial tears, their ingredients and their preservatives. Um, that's really kind of confusing to kind of digest. Um, but here's something that's a little more uh, treatment guided in terms of which tiers are designed to treat which different inciting causes of dry eye. And I think we made even a simpler view of this in terms of, the more stars means it's going to do better at treating specific causes. I wanted to spend one slide talking about artificial tear contamination. It's often patient use related, so bottle to eyelid contact or extended use of artificial tears can lead to contamination. In some studies, up to 30% of bottles. That's usually the tip, not actually the tear with reservoir within the bottle. But that's something to keep in mind that a patient should have good technique in applying the eye drop, not press it up against their eyelid. But then there have been some episodes of manufacturing contamination. In 2022 and 23, there was a Pseudomonas contamination in some artificial tears that were actually manufactured in the United States. There were 81 cases of complications from this across 18 states. There were 4 deaths from artificial tear contamination and 14 cases of vision loss, including 4 enucleations, which is surgical removal of the eye. So, artificial tear contamination is not um, unharmful, event, and was this sentinel event in 2022 and 23 that really reminded us of this. For this reason, in my own personal practice, I usually say, this is one of those cases where if my patient's starting artificial tears, I say, get a branded artificial tear where this issue has not occurred, or this issue did not occur back in 2022, 2023. So in conclusion, I'd say ocular surface disease, an umbrella term. It encompasses a family of diseases that affect the ocular surface. It can have significant morbidity, and ideally, treatment approaches should be multi-tiered and address the underlying cause. I will tell you, like when I talk to my patients about this, my main message is that if you try an artificial tear and you're using it for 2 weeks and you find that brand's not good for you, just switch. You will find something that works better for you. And artificial tear formulations contain a variety of ingredients that are designed to target different ocular surface disease causes. So I'd like to thank you all for your attention, and I'm happy to take questions. I think, wait, there's a post-test clinical vignette. So we're back to the 68-year-old woman, fluctuating vision, burning and worsening symptoms late in the day. Examination demonstrated those lid margin telangiectasia, thickened meibum, reduced gland expressibility, rapid tear breakup time, and meibography showed gland dropout. Her Schirmer test, which is her tear amount, was actually normal. So which of the following is the most likely primary mechanism? So again, aqueous tear deficiency, goblet cell dysfunction, meibomian gland dysfunction, neurosensory dysregulation, or lacrimal gland insufficiency. And sorry. So the answer for this with the telangiectasia is, yep, 100%. Wow. There you go. No questions there. Great job. And clinical vignette number 2 is, I'm going to stop sharing my screen. Thank you for your attention.
And we'll start off with another clinical vignette. This, hold on. This is a 65-year-old woman who presents with severe bilateral central corneal punctate epithelial erosions with best-corrected visual acuity of 20/40 in each eye. Corneal sensitivity was reduced with a Cochet-Bonnet esthesiometry reading of 3 out of 6 in both eyes, which indicates about 50% reduction in sensitivity. She has a history of seasonal allergy and itchy rash on her elbows and cataract surgery in both eyes over the past 3 months. Postoperative eye drops were finished about 3 weeks ago. What's the probable cause for her corneal epithelial disease? A, allergic keratitis, B, neurotrophic keratitis, C, medication toxicity, and D, Demodex blepharitis. Well, as I mentioned, I'm Steve Flufelder. I'm a cornea and ocular surface specialist at Baylor College of Medicine in Houston. And I'm going to talk to you about neuromodulation in managing ocular surface disease. And this is a therapeutic area that's getting increasing amount of attention. The lacrimal functional unit maintains ocular surface homeostasis, and it consists of both an afferent branch, which are sensory branches of the trigeminal nerve that densely innervate the cornea, as you heard about from Dr. Pitha, and they travel to the trigeminal ganglion in the pons, and then they synapse with cortical regions as well as other areas in the brainstem, including the secretory and motor nuclei of the seventh nerve, which represent the efferent branch of the lacrimal functional unit. And the autonomic branches innervate the main and accessory lacrimal glands, meibomian glands, and conjunctival goblet cells that you just heard about. and the motor branches initiate blinking, which is very important in spreading and clearing tears. And these are the structures that would modulate with neuromodulatory therapies. And the cornea is one of those targets for neuromodulation. The cornea has the highest density of noxious stimulus receptors, termed nociceptors, of any tissue in the body, about 300 to 600 times greater than skin and about 20 to 40 times greater than tooth pulp. And these nerves are susceptible to infectious, inflammatory, traumatic, and surgical insults, both in the nerves and the axons that travel to the trigeminal ganglion. And you can see that the nerves form this beautiful vortex in the cornea. It's amazing that when we look through the cornea every day, we're actually looking past this plexus, which is found in the basal corneal epithelium. And there's an intimate relationship between the corneal epithelium and these nerves, as you can see here, that they're kind of wrapped, that the basal epithelium wraps around the basal nerve terminal, and then they branches from the basal plexus extend toward the apical surface of the corneal epithelium as nerve terminals to sense the environment. And so it could be mechanical, chemical stimulus, or cooling, which occurs during the interblink interval, and which helps to drive a basal tear secretion. And these corneal receptors, as I mentioned, respond to different types of stimuli. The TRPM8 receptors, which are targets for Coltramon, which is a recently FDA-approved therapy to stimulate tear production, stimulate basal tear secretion, again, driven by the slight cooling, about 1 degree Celsius, that occurs in the interblink interval. And as I mentioned, the TRPM8 agonist, Coltramon, was found to significantly increase tear secretion. About 43% of patients using that had a greater than 10 millimeter increase, compared to only 8% of vehicle treated. So it's very effective in stimulating tear secretion. Other nociceptors include the mechanoreceptors, which have piezo2 receptors, polymodal receptors, which have primarily TRPV1 receptors, and then there's high and low threshold cold receptors that have TRPM8 receptors. Neurotrophic keratitis is a degenerative condition induced by impairment of the trigeminal nerve. Impairment or loss of the corneal sensory innervation is responsible for development of corneal epithelial defects, frank ulcers, and occasionally perforation. NK has multiple etiologies that may not be easily recognized. The number one cause, at least in the one of the phase 3 clinical trials for a recombinant NGF, was herpes zoster ophthalmicus. But other causes include brainstem neurosurgery, cerebrovascular accidents that affect the brainstem, diabetes, especially long-standing type 1 diabetes, chronic keratoconjunctivitis sicca, ocular surgeries, including penetrating and lamellar keratoplasty and scleral buckle procedures, corneal dystrophies, including lattice and Bowman's layer dystrophies, limbal stem cell deficiency, drug toxicity, primarily glaucoma drops and their preservatives, as Dr. Pitha mentioned, and chemical injuries. NK is diagnosed in eyes with reduced or absent corneal sensitivity. And if corneal sensitivity is not reduced, you should probably consider other causes for chronic epitheliopathy or persistent corneal epithelial defects. And there's a variety of options to measure corneal sensitivity, including the simple ones like a cotton tip applicator, dental floss, or the Cochet-Bonnet aesthesiometer that's been around for several decades that it basically is an extensible monofilament nylon. And now we have a new option, a non-contact air aesthesiometer that can mount on the slit lamp and has 5 levels of stimulation. And persistent corneal epithelial defects or chronic epitheliopathy from any cause is associated with reduced density of the epithelial nerve plexus and sensitivity. It's probably a good idea to utilize a stage treatment approach for NK based on clinical severity. And the classic classification of NK into 3 stages was proposed by Mackey back in the mid 1990s. Stage 1 includes or manifests as punctate epitheliopathy. They can look a lot like moderate to severe dry eye. Stage 2, patients develop corneal epithelial defects, and then stage 3, they can develop stromal ulceration and stromal lysis. A bit more granular staging scheme was proposed by the neurotrophic keratopathy study group. There was a committee formed by Ascaris, and they proposed 6 stages of NK ranging from mild stage 1, in this case, altered sensitivity without keratopathy, as opposed to the Mackey stage 1, which has keratopathy, and then running all the way to stage 6, which is corneal perforation. For stage 1, it's important to identify and address ocular and systemic causes for NK. As I mentioned, type 1 diabetes, particularly with proliferative diabetic retinopathy, is associated. So those patients want to be treated adequately for their systemic disease. Chronic topical glaucoma therapy, it might be possible to modify their therapy to get them off preservative-containing agents. Neurodegenerative conditions like dysautonomia and Parkinson's disease. I end up diagnosing Parkinson's disease about once a month in patients that have reduced blinking and reduced corneal sensitivity. And virtually all eyes with stage 1 NK are dry and need to be treated for dry eye, as Dr. Pitha mentioned. For stage 1, then, it's important to address the comorbid diseases and factors to eliminate toxic preservatives, treat the dry eye. Doxycycline is an anti-inflammatory and anti-protease agent that can help to preserve corneal barrier function. And there's been a lot of recent interest in using topical insulin. And then to support, protect, and restore the nerves or the ocular surface using scleral lenses. Neuromodulation with Synedgermin, the only FDA-approved therapy at this point for NK, and then autologous serum or plasma-rich and growth factor drops. Additional considerations for stages 2 and 3 include conditions with permanent nerve loss or dysfunction that require chronic support and protection. And these might be patients that have undergone trigeminal nerve ablation or resection for trigeminal neuralgia, gene mutations such as the IKB-KAP and familial dysautonomia, severe zoster that where the nerves have really been destroyed, and then severe diabetic retinopathy. For stage 2 and 3, the treatments are the same as stage 1, but you can consider additional therapies like amniotic membrane grafting, which amniotic membrane has growth factors in it, as I'll mention, to help to heal the surface. Botulinum toxin to induce temporary ptosis. Keratoplasty should be reserved for severe corneal thinning, desmetocele, and perforation. And then same neuromodulatory therapies that we discuss. And then neurotization can be considered, particularly in those conditions, like I mentioned, that have little chance of actually recovering their own innervation. Scleral lenses were initially reported to heal persistent corneal epithelial defects in 2003, and they've been gaining traction over the last few decades. Epithelial defects healed in all patients who failed bandage contact lenses, but recurred in about 90% when scleral lenses were stopped, but they healed again when they were resumed, and visual acuity improved in almost 90%. Scleral lenses may be safe and effective treatment option for any stage of NK by preserving epithelial integrity and improving visual function. Amniotic membrane, as I mentioned, is a good option to stabilize the neurotrophic keratitis and promote epithelial healing and suppress keratolysis. The amniotic membrane provides growth factors and substrates as it dissolves, and there's a wide variety of forms available, including fresh, frozen, and self-retained preparations or sheets, and then lyophilized discs and sheets. The efficacy of single or multi-layer fresh frozen amniotic membrane for treatment of NK ranges from 55 to 89% epithelial healing at 1 month or longer, and multi-layer grafts have been reported to seal and heal small perforations less than 1 millimeter in diameter. As I mentioned, there's increasing reports of efficacy of insulin. About 90% of stage 2 and 3 NK healed within 7 to 45 days with topical insulin at the concentration of 1 unit per ml, which is the one that we currently use. And 19 or 18 plus or minus 9 days in stage 2, and a little bit longer, up to about 30 days in stage 3 to see complete healing, and best corrected visual acuity significantly healed in both stage 2 and 3 NK. Insulin significantly reduced the size of small epithelial defects over 20 days, while moderate epithelial defects had slower healing in another more recent report. Now I'm going to talk about neuromodulatory treatment of NK, and that would be Synedgerman ophthalmic solution. It's a recombinant human nerve growth factor and the first FDA-approved agent for NK. In the US, it's indicated for treatment of all stages of NK from stage 1 to 3, and in the EU for moderate to severe NK stages 2 and 3. The drop has to be refrigerated and can last up to 14 days when it's refrigerated. It's supplied in cartons of 7 multi-dose vials, each 1 ml, and it's administered 6 times a day for 8 weeks. Synedgerman may take weeks for approval by the carrier, so plan for an alternative initial stabilizing therapy until the patients can get that treatment. About 70% of Synedgerman versus 29% of vehicle-treated patients healed to less than 0.5 millimeter epithelial defects, and complete healing was observed in 65% versus 16.7% in the vehicle group at 8 weeks. The effect is durable, with 96% of corneas remain healed at 1 year, and increased corneal sensitivity, reduced corneal neovascularization, and visual acuity were reported to improve in one case series of 11 treated eyes. Synedgerman binds to NGF receptors on the corneal epithelial cells, and there are 2 NGF receptors, the TrkA receptor, which is a high affinity receptor, and the P75 receptor, which is a low affinity neurotrophin receptor. And you can see on the right that this is immunostaining for both receptors, with higher density of receptors at the limbus for track A, and both in the limbus and the cornea for the P75. Receptor activation triggers intracellular signaling pathways that promote epithelial proliferation and cell survival. And epithelial healing can help to restore the epithelial nerve plexus that I showed you. And these are graphs from both the EU and the US registration trials. And you can see by week 8 in both the EU trial here and in the US trial here, the results are very similar with about 72% complete healing in the EU trial and 65.2% in the US trial. So that shows that the results are very reproducible in multi-center studies, both in the EU and the US. If you look at the epithelial defect size, and these graphs show the mean percent reduction in lesion size at week 8, the Synedrimin group had a 36.3% decrease in lesion size, where the vehicle group actually had about a 46.8% mean increase in the lesion size. So even in those that didn't heal, there was a marked reduction in the size of the epithelial defect. And these are actually eyes taken from some of the, or photos from one of the eyes treated with Synedrimin in the Reparo trial, one of the registration trials. As you can see, diffuse white light on the top, where you can see the epithelium healed, and then a disappearance of the corneal fluorescein staining below. Adverse events were very minimal. Those of you that have used Synedrimin probably recognize that a small percentage of patients will develop some eye pain in about 1 to 2 weeks into treatment, and that will usually go away. So patients have to be counseled that can occur perhaps as they start to regain some of their nerve function and corneal sensitivity. But all of the other adverse events occurred with very low frequency and were similar in both the Synedrimin and vehicle groups. Serum and plasma-rich growth factors have also been used to treat NK, and 20% autologous serum healed 71% of epithelial defects at 6 weeks and 92% at 12 weeks. And platelet-rich plasma healed about 97.4%, quite high, of epithelial defects at 11 weeks. Both blood products have been reported to improve corneal sensitivity, and serum was found to increase the density of the basal nerve receptors. Neurontization of the cornea was initially described in 2009 by Terzis, who reported improvement in corneal sensitivity, visual acuity, and corneal health in all 6 eyes treated with transfer of the contralateral supratrochlear and supraorbital nerves to the limbus of the fellow eye. And there are other direct and indirect options now that have been reported for nerve grafting, including ipsilateral supraorbital nerve, ipsilateral infraorbital nerve, and the sural nerve, which is what my colleague uses. It's a preserved sural nerve, or the greater auricular nerve. If you start initial therapy and it doesn't work, then it's a good idea to consider other treatment options. So then you can either restart initial therapy such as Synedrimin, or switch to one of the other therapies that I mentioned. I'd like to conclude quickly with neuromodulation of blink disorders. In benign essential blepharospasm is a focal dystonia manifested by involuntary eyelid protractor and periorbital muscle spasms, leading to uncontrolled closure of the eyelids, repetitive facial and eyelid movements and twitching, and increased frequency of spontaneous blinking. Patients have associated severe photophobia, and it can lead to functional disability due to forced eyelid closure. These patients can also develop filamentary keratitis and superior limbic keratoconjunctivitis due to the frequent forceful blinking. Neuromodulation with Botox or botulinum toxin has been reported for blepharospasm and for refractory filamentary keratitis that hasn't responded to one of these medical therapies listed here. Botulinum type A toxin inhibits acetylcholine release from the presynaptic neuromuscular junction by cleaving SNAP25. It produces temporary chemodenervation and muscle relaxation. Onset is within 3 to 7 days, and duration is usually lasts for 3 to 4 months. This is the typical treatment protocol, injection protocol in the orbicularis, lateral canthus, and eyebrow. And the dosing is 1.25 to 5 units per injection site. So in summary, neuromodulation of the lacrimal functional units is effective in treating cornea and ocular surface diseases. Recombinant human nerve growth factor is effective in healing corneal epithelium and NK. Botulinum toxin can improve blepharospasm and filamentary keratitis. And effectiveness of these therapies may spur development of other neuromodulatory therapies. I'd like to conclude with the post-test vignette. And again, this 65-year-old woman with severe bilateral central punctate epithelial erosions with visual acuity decreased to 20/40, reduced central corneal sensitivity. She has a history of allergy, an itchy rash in her elbows, and cataract surgery 3 months ago, but has been off drops for 3 weeks. What's the probable cause for her epithelial disease? A, allergic keratitis, neurotrophic keratitis, medication toxicity, or Demodex blepharitis. And I didn't actually show how we did, but now we can take some questions. Oh, here we go. And over 86% of you got the correct answer, neurotrophic keratitis. To receive your CME or CE certificate, please ensure that you attended and fill out the brief of evaluation. And this, you can complete the evaluation until December 9th of this year. I'm going to stop sharing. And there are 3 questions. Dr. Pitha can join us again for these. First one is, what's the most frequently used ingredient in the latest artificial tear formulas for management of ocular surface disease? Ian, yeah, what would you say?
Um, I mean, when we're talking about the lubricants, let me look at my slide so I know that, so I can be kind of.
I would say, in my experience, hyaluronic acid is gaining increasing traction. A lot of people are very happy with HA containing tears.
Yeah, no, I agree with that. I do feel like it is still not the most common, but it is, I
Right,
thought
I agree.
carboxymethylcellulose has been very popular, but I think hyaluronic acid has distinctive advantages over that. It's viscoelastic. It kind of withstands um, the tearing. It can change with blinking very well. So, yep.
Our
Very good.
second question is, are tryptamate agonists used in natural tear production for the management of ocular surface disease in community ophthalmic practice? Well, the answer is yes, it does stimulate natural tear production, both from the lacrimal gland and from the meibomian glands. And there's a suggestion that it also stimulates the conjunctival goblet cells, so all the natural tear components. And there's no reason why it can't be used in the community. It's FDA approved and I believe it's gaining increasing use. Have you used that, Ian?
I've never used it. No.
I,
Do you use it
I,
frequently?
yeah, I use it quite a bit now, especially for aqueous deficient patients and for patients that need more tear clearance. And it's really great medication. The only side effect that I do encounter occasionally is that some patients complain of burning, but that's a small percentage, and usually they adapt to it. Um, And then our last question is sunetrimine being actively used in the management of ocular surface disease in community ophthalmology practice, or is it restricted only to tertiary medical centers? I think I know a lot of community practices and practitioners here in Houston that use it, both optometrists and ophthalmologists. So again, it's one of the medications that is FDA approved, and it certainly can be used by anyone. There was one other question, I think, about castor oil, but I don't see that. Let's see. In any case, you guys have been a great group. Thanks for joining, uh, and then please claim your CME certificate. Ian, do you have any closing words?
No, no, I don't. I think my primary treatment of dry eye disease is trying to get people off glaucoma drops. But, I think,
And it's good you have so many other options these days for
yeah.
that. So,
All right.
well, thanks everyone. Have
Thank
a good
you.
day.